Well, good afternoon, everyone. Welcome to our second hospital readiness webinar. My name is Daniel Moran. I have the honor of being the Vice President of Education for Antevy. We're thrilled to have you here, and we know today is going to be an amazing webinar for you. I promise it'll be an unforgettable presentation that includes a story of cardiac arrest survival, and hundreds more are actively being saved because of the presenters we have on today. Before we begin, a couple of very quick housekeeping items. Please keep your mics on mute to minimize background noise. We encourage questions. Put them into the chat. We'll try to respond real time. And we're hoping at the end of the presentation to have a little bit of time for Q&A. We will be recording today's presentation, and we do plan on sharing it afterwards. We're especially excited about today's webinar because we have an incredible guest joining us. You're going to hear one of the most powerful stories we've ever come across about survival and the work that's being done to save countless children's lives. I'd like to introduce Jen Hayes. Jen is a PICU critical care nurse and an educator who has dedicated her career to improving every link in the chain of survival. She is responsible for leading efforts to ensure that when a child's life is on the line, the right people, the right processes, and the right training are in place to give them the best chance for survival. And of course, we're honored to have Dr. Peter Antevy with us today as well. Many of you know Dr. Antevy is a leader in pediatric emergency medicine and resuscitation. Today, he's going to dive deep into why pediatric readiness matters and how hospitals can elevate their approach to pediatric emergencies. With that, let's jump in. Dr. Antevy, I'll turn it over to you.
All right, Dan, thanks so much. And Jen, welcome. Welcome to the webinar. Just a quick story. I was very honored to meet Jen several years ago, and I told her this the other day, but I remember leaving that room after she gave her talk, and I said, "This woman is a unicorn. She's such a special human being." And I remember leaving saying, "How come there aren't any other people like her in this world?" And really, when you hear what she's doing, and what I think everybody should be doing, you'll, I think, all agree. And as Dan mentioned, her story is very special, very emotional, and you'll understand quickly why. Before I do turn it over to Jen, for the people on this call, I know we have nurses, we have physicians on the call, we have paramedics on the call, and you for sure have heard about pediatric readiness. I'm going to start by just going over a few slides on why this is important, and then Jen's going to take it to a whole nother level, and you'll see exactly what I'm talking about in a minute. But before we get to Jen, let me just fess up a little bit. And for people who don't know, as a pediatric ER doc, I made a 10-fold medication error very early in my career. I gave 10 times more epi than I was supposed to a little 4-year-old girl who was in anaphylaxis. She ended up in the ICU that night because of my error. I was ashamed. I was embarrassed. And that wasn't the first mistake I had ever made, by the way. And that started my mission to say, how do we fix what's going on here in this world? And quite frankly, I don't think many people thought there was really a problem. However, and really, I put these up here because these are the hospitals I trained at. And this wasn't supposed to happen to me. I was supposed to be the smartest guy in the room. I mean, I was the dumbest guy in the room, it turned out. But it turns out that I wasn't alone. And recently, many of you may have read these articles, but it's now in the media. The media now understands how rampant errors are in the emergency department. We know how errors are rampant in EMS. But let me just take you through a quick couple of slides to make you very aware that there's 34 million ER visits every year. What most of the population doesn't recognize is that 80% of those children are not seen in Children's Hospital of Orange County, Joe DiMaggio Children's Hospital, Boston Children's Hospital. No, they're seen at the local community hospital, right? And so when you start to look at how ready these other hospitals are, you start to recognize that there's a lot of work that needs to be done. The Wall Street Journal in October 2023 published this very powerful article. The 2 children you see on the screen are no longer with us. These children died because of medication errors and other errors, such as diagnostic errors in the emergency department. Through the data that I'm about to show you, they found that only 14% of ERs are certified as ready to treat kids. That should be striking to each and every one of us. Children are 4 times as likely to die in less prepared emergency departments, 4 times, 400%. And in the 5-year period, over 1,400 children died because of errors in emergency departments in the United States of America. So we now know that all ERs are not created equal, but the question is, how do we change that? And again, here's the New York Times article. This is November 2024, folks. This is just a couple of months ago. So the lay public now wants answers. Our politicians now want answers. People are going to have to now start to really ramp up their readiness. And really, that's why we've started this pediatric readiness series, and we're bringing in experts like Jen Hayes to really help everyone understand what the work that needs to be done. So I have a couple of cases up on the screen. I don't want to get anyone nervous or anxious, but these are all cases that came in when I was working in the ER, not all the same day, thankfully. But just imagine you had a kid in septic shock, rollover MVA. I had a 5-year-old shot in the chest by his father on accident, 8-month-old actively seizing. Another screw up I did, norepi drip in a 7-year-old. I knew I needed it, didn't know how to mix it, didn't know how to run it. And at a children's hospital, a chest tube for a 5-year-old. Just go down the list. What about if you had to transcutaneously pace a 10-year-old, which I had to do at 2 o'clock in the morning on a Sunday? I'll never forget that day, right? So you can understand, but just by looking at this screen here, that you could be in pediatric emergency medicine and still get nervous by this, but then you could be working at the community hospital where you see mainly adults, and it gets even more anxiety provoking. And that's really why we exist. And that's why we're putting on webinars like this, and that's why we're bringing people like Jen Hayes here. What I did back in 2005, I just started something called the Code Committee. We just every month we just started doing this. Obviously, Jen takes it to a whole nother level, which you'll see in a minute. However, the question comes up, what if someone developed a pediatric ready scoring system? And we have this person to thank, Marianne Gachet-Hill. She's had a very storied career out in California, and she came up with this National Pediatric Readiness Project. If you work in an EMS, there's an EMS readiness project. If you work in the hospital, there's a Pediatric Readiness Project for hospitals. Here's what it does. And again, busy screen, but there's over 175 items that you need to check off to say, yes, I'm ready, and actually get these done. But by the way, very few of these items relate to CPR quality, CPR metrics. So it says, yeah, you ought to know how to run an arrest, but it's nothing like what you're about to hear. So my point here is that pediatric readiness is important. It's kind of step one. And then we want you to go to a whole nother level with respect to CPR metrics. And after Jen speaks, I'm going to bring in Dan Moran, who was my EMS chief at Davie Fire Rescue until he retired and we stole him away. But he's going to show you what he did on the EMS side to show you how you can bridge the gap using metrics, using data, specifically around cardiac arrest in kids. That's what we're really focusing on today. Some of the questions in that survey, they're pretty basic things. These are not cardiac arrest items. One of them that we care about is they ask you, do you have a process in place for pre-calculated dosing in all children? We care about that. But overall, they grade you. You take the survey, you get a grade. I like the Amazon star system. You either get a 1-star, which means you get a failing score. You get a 2-star, 3-star. If you get a 4-star, you're considered pediatric ready, right? But unfortunately, only 14% of hospitals around the country achieve that goal. And if you can see here, here's some odds ratio plots with respect to medical patients, respiratory patients, neurologic patients. They all do better with respect to mortality at a 4-star hospital. What about injured patients? This is all trauma patients. Only the 4-star hospitals make a difference. So now what is the world seeing? What is your community seeing? What are your politicians seeing? They say, we want everybody to be a 4-star hospital. Make it happen. That's what they're going to tell you to do. So, and the final slide, which is the important one, this is like the money shot, that the mortality at a 4-star hospital is 3.4%. At a 1-star hospital is 11%. That's where you get that 4-fold difference in mortality based on how ready you are. So all of us, no matter if you're at a children's hospital, you're at a community hospital, you need to focus on getting pediatric ready. It takes time, it takes people, it takes doing it right. That's phase one. Now you want to get to the next step and you want to be like Jen Hayes. This is where we're going to exist now for the next 30 or 40 minutes. And that says here emergency department because this is kind of my home. It's where I love to work, and it's where I worked my entire career. But Jen is going to talk to you about cardiac arrest anywhere in the hospital. And what I love about this photo is that tell me who the doctor is, tell me who the nurses are, who's medication nurse, who's documenting, who are the students, who's respiratory, who's focusing on the CPR that's being done. And then when you leave the room and everything's on the floor and blood everywhere and people are, upset and so forth, who comes after you to say whether or not the job that you did was good? Introducing Jen Hayes. So Jen is that person. She is what I call the unicorn in a very good way, obviously, Jen. And so what I want to do now is welcome Jen to the webinar, and she'll go ahead and share her slides. And what you're going to hear is really a story of perseverance, of wicked smartness, and something that we should all hope to achieve in the future. So Jen, take it away.
Well, thank you so much, Peter and Dan, for having me, and everyone for taking the hour to be here for this webinar. This is something that is so incredibly near and dear to my heart, and pediatric resuscitation has really been something I've been incredibly passionate about since I was in nursing school, and that's what really drove me to become a nurse in the pediatric ICU. And then in 2017, the Children's Hospital of Orange County created a role that was dedicated to resuscitation. So I'm now the supervisor of our resuscitation program. And in that, I basically oversee every single link in the chain of survival, the quality improvement, the research, the education, processes for the entire institution. So that includes our emergency department. I partner very closely with them. And so today we're really going to dive into, like Peter said, the pediatric resuscitation, the cardiac arrest piece of it. And let's see. Some disclosures. So I do speak for Zoll Medical. I do receive compensation and travel reimbursement. This is not a supported talk by Zoll. And then I am on the AHA PALS writing group. The piece that's in italics here is very, very, very important. The views and opinions that I'm expressing today are completely my own, and they do not reflect and are not endorsed by the American Heart Association. So please do not take anything that comes out of my mouth as an official position of the AHA, because we will be talking about some things that may be a little controversial. And I just want to make that very clear. And then, of course, always follow your agency or organization standards of care. So objectives today, we're really going to dive into quality improvement, continuous learning, and how we can make actually significant improvements in CPR quality. We're going to really examine the role of data in improving our pediatric resuscitation. And then with a focus on both prevention and CPR quality, really discuss steps that we can take to improve our outcomes. The bulk of our time is going to be spent on, like I said, CPR quality, but please remember that the entire link, every link in the chain of survival has very important pieces that need to be addressed to really create this strong chain that ultimately improves our outcomes. So I come to you from Chalk Children's Hospital in Southern California. We are a freestanding children's hospital. Level 1 trauma center. We have 356 beds with 66 critical care beds, 104 NICU beds, and 36 ED beds. I share that with you because that's where pretty much all of our cardiac arrests take place. And on average, we have between 70 to 80 cardiac arrest events each year. So this is a very busy slide and not intended for you to be able to read, but I think that it really highlights a key driver diagram that if we want to increase and improve survival from in-hospital cardiac arrest, there's so many things that we can do. And the question always is, where in the world do I start? Because it can be very overwhelming to look at this. And I wish that I could give you a step 1, step 2, step 3, step-by-step direction. I'm going to do the best I can for you on that. But the reality is that improving resuscitation quality, especially in the pediatric world, but a lot of what we're talking about today can really be taken throughout your organizations, throughout your EMS agencies, regardless of age. But it really looks more like this, that you kind of hit forks in the road and you don't really know what direction you're going, you kind of have to turn around based off of the data that you're seeing. So really our goal today is to really help you be able to strive for a culture of resuscitation excellence in your agency or at your institution. And the big piece of this is really getting to the place where people believe that they can actually make a difference. I mean, how many of us have responded to, numerous cardiac arrest events? And I know in my bedside days, there were certainly moments that I was like, oh my gosh, here we go again. Like, we're going to do CPR again, and the kid's not going to survive. And, we tend to potentially get a little jaded because we don't always see the positive side of cardiac arrest. And so we really need to shift the focus to help our staff see that small changes can lead to huge improvements in outcome. So when I started this, many of you may be in the same exact boat. I really, truly believed that there was absolutely nothing that I could do on the in-hospital side to improve CPR quality, resuscitation quality, or outcomes. I very much kind of fell into the camp of, we're amazing, I'm a PICU nurse, we're always there, we do amazing CPR. Like, it's Peter and his people that need to fix this, right? Kidding, Peter. But, really, I really didn't think that there was much improvement that could be made. And, when we look at the in-hospital chain of survival for pediatrics, this is really where pediatric resuscitation readiness starts. And I'm using in-hospital. I know many of you are treating patients who have out-of-hospital cardiac arrest, whether you're in EMS or you're receiving children who have had an out-of-hospital cardiac arrest. The chains are pretty similar. And the reason why I'm focusing on the in-hospital piece is because if a child has a cardiac arrest in front of us, even though it's not necessarily in the doors of the emergency room, or maybe it is in the doors of your emergency department, there are things in that first link with recognition and prevention that are really key for us as healthcare providers to pick up on and intervene on. And that's why I'm really using the in-hospital link or chain of survival. What we know is that besides prevention, high quality CPR is absolutely the foundation of each one of these links. If you do not do high quality CPR, all of your advanced resuscitation, post cardiac arrest care, it doesn't matter as much. It's not going to be as powerful if you are not perfusing the heart and brain. So we all know the components of high quality CPR, right? Rate, depth, release, minimizing interruptions, avoiding hyperventilation. And we know that the American Heart Association tells us that high quality CPR is the primary component that influences survival. And yet we know that it does not translate into practice. These are just pediatric specific. Actually, I'm lying to you. There are a couple adult articles in here, but the majority of these are pediatric specific articles looking at healthcare professional CPR quality. And we know that we do a horrible job at hitting correct rate, correct depth, full release, pause times, pre and post shock pause times, pulse rhythm check pause times. We know we do a very poor job. And if you are anything like me, I can read this and say, yeah, that's really nice. There's no way that chalk is that bad. There's no way that my agency is that bad. Like, we are amazing. And so we really find ourselves in this predicament where there's a lot of data that says there's opportunities to improve, and yet we don't believe it because we don't trust that that's actually how we're performing in our institution. What we know, though, is regardless of how well you think you're doing, survival requires perfusion, and perfusion requires high-quality CPR. And if that's the case, I would encourage each of you to focus on high-quality CPR, because without it, what are we perfusing? And the reality is we truly only have one chance to get this right. There's no do-overs, right? This is not like an IV start that you're like, shucks, I missed it. Let's try again, right? We've got one chance. And I always like to think about this as if this was my loved one, if this was my loved one who was receiving CPR, would I be willing to sit there and be okay with them getting subpar resuscitation quality? And I think all of us would agree that the answer is no. And I really, really, truly believed this. And then in 2017, I actually then found myself on the other side. So in 2017, I had just taken my resuscitation role. And my husband, Kyle, and I had just celebrated 11 years of marriage. And we're really enjoying time with our son, Matthew, who was 3.5 at the time. We found out that year that I was pregnant and we were going to have our second son in 2018. And I have to tell you, I loved being pregnant. It was a very smooth, very, very comfortable pregnancy. November 9th started in 2017, started as a completely normal day for me. I went to work, gave a resuscitation report, and then came home. And that evening, my husband and I went out to dinner with Matthew. And as we got home, I took Matthew upstairs to bed as usual. Shortly after entering Matthew's room and placing him in bed, I collapsed. And in that moment, my personal and professional lives collided just 4 short months after taking over Chalk's resuscitation program, when at 30 weeks pregnant, I suffered an out-of-hospital cardiac arrest. So my husband and neighbor did CPR with guidance from the dispatcher. And 5 minutes after the 911 call was made, the first responders arrived. And in their hand was a device that offered CPR feedback. And they were a very data-driven agency. So they placed the feedback pads, took over compressions, identified that I was in VFib. That is really my rhythm. Sometimes I have to remind myself that that does say my name. And they took over compressions. One shock was delivered, and then they continued the ACLS algorithm. I got, the entire algorithm. I was shocked twice. I got 15 minutes of CPR. An IO was placed. I was intubated, and then I was airlifted to a tertiary high-risk OB center near home, where they did very quick and extensive testing and decided that the likely cause of my cardiac arrest was eclampsia. So the cure was to deliver our son. So in the early mornings of November 10th, our son Micah was born. And he was born limp gray, not breathing, 1,600 grams. And following my C-section, as you saw on that last slide, they did targeted temperature management. So I was in the hospital for 8 days total. 4 days later, after my arrest, I met Micah for the first time. Matthew came to visit him. And then as I was discharged, Micah was transferred to Chalk, which really became our home away from home. And really not knowing how the cardiac arrest had affected him, we really celebrated all of his achievements and milestones. And after 71 days, Micah came home and made our home complete. I have to say, and I always like to give this little view because, with how much I've done with cardiac arrest, I really, truly always thought, like, we just saved your life, go live it. And I very quickly came to realize that being a cardiac arrest survivor is not that easy. And the emotional toll of it is just overwhelming. I couldn't go in Matthew's room alone. I had significant panic attacks, postpartum depression, severe anxiety, and really had this fear that each and every day was going to be the day that I was going to have another cardiac arrest, and this time maybe not be so lucky. So as we went through all of this, we continued to celebrate Micah's achievements. I did wear an external defibrillator for 7.5 months. At home, Micah really continued to just grow and thrive. And I was off work for 10 months. And when I returned to Chalk, I really had this reinvigorated passion to really look at what does our CPR quality look like, and how do we ensure that every single one of our patients are given the same exact chance that Micah and I were given on the night of my cardiac arrest. And so we really started this huge quality improvement project looking at our CPR quality. And my computer, I apologize, my computer's being silly. This is a quote that I kind of live by when it comes to resuscitation quality, because like I said, I really thought that we were amazing, right? And I didn't have any data to support that. So really, without data, you're just a person with a hopefully really great opinion. But until you have the data to support that opinion, you can't say it's accurate. And we were absolutely in this camp. My physicians that I worked with, my nurses, respiratory therapists, my multidisciplinary teams really felt we were doing very, very well. And data really is what tells your story, right? And so at this point, I felt like I was way down here, like not even at base camp, and really felt like I don't even have data. And that, in my mind, was worse than having data that showed we were doing a terrible job, because at least I wasn't living in this like fog of thinking that there was nothing that we could improve. And so many of you may feel like this right now. By the end of this presentation, you may feel like this. And I'm going to tell you, like, do not lose hope. Do not give up. We're going to talk through some like first initial steps towards the end that can help you take that first step. For us, we didn't have feedback pads. The defibrillator was never brought to the bedside because we were like, we only use this twice a year to defibrillate our PEDS patients. That just collects dust, right? And so we had a ton of work to do. And really, we know that data is what tells our story. So I'm going to ask each of you to really think about, what data do you currently have and what story is it telling? When you think about your pre-arrest identification and prevention, whether it be in the back of an ambulance or in your emergency department, or if you're, outside of those two areas and you work in a different unit, in that unit, are you identifying pediatric decompensation? Because it looks very different than adult decompensation. The cause and etiology of the arrest in pediatric patients are going to be so different than adults. And so, are we identifying that early? Are we trying to prevent the arrest? The highest quality of CPR is no CPR at all. That's my motto, right? And then if we can't prevent it, we're going to make sure you get the best quality of CPR possible. Do you know all about your arrest? The out of hospital, the kids that come in and then arrest in your emergency department, or you get into the back of your rig and then they arrest. Do you know about all of those, and are they being reviewed? What about your quality of resuscitation? You don't have to have a fancy machine to look at quality of resuscitation. Yes, it certainly can help with components of it, but it's not the end all be all. So, if you have a machine that's giving you some CPR data, where are you at with rate, depth, time to defibrillation, pause times during your CPR? What about EMS to ED handoff? How much are we pausing when we're doing that handoff? What about your epi doses, intervals? Are you following PALS guidelines, especially if you're in a community center where you may not see very many pediatric cardiac arrests each year? This is not something that is your bread and butter. And so how do we then look at this and say, this is what our data is showing, here's where we can improve, here's where we're doing really well. And then outcomes, ROSC rates, survival rates. So I'm gonna air our dirty laundry here. In 2017, we had gone through a series of steps to start collecting our actual CPR quality data off of actual real life events. And here's the first 6 events we got. It was, quite humbling. Our whole "we are amazing," that was clearly just an opinion because our data was really showing otherwise. And remember, these are all pediatric patients, and each one of these events happened in our pediatric ICU. Not a single one hit 10%. And in total, we basically found that only 4% of our compressions were being delivered within the American Heart Association guidelines. So that's like any of us going to an ECMO surgeon and saying, hey, that ECMO pump, it's only working 4% of the time. So not sure what you're going to do. You got to go ahead and figure out that other 96% because all we've got for you is 4. Right. So this was so incredibly sobering. Our compressions were too fast, 71% of the time. And our survival to hospital discharge was 26%, which for you that work in the adult world primarily, you probably feel like that's amazing. In the pediatric world, that's terrible. We see survival rates in the in-hospital setting upwards of the 40s. So this was pretty telling to us. And what this data really started to do was tell us our story. It started to tell us the opportunities that we had. So we needed to get CPR feedback onto each and every one of our patients every single time. And that was a huge, huge, huge culture shift. And really start changing the staff's view of the defibrillator. Because everybody saw it as, we just pull that to the bedside if we're going to defibrillate. And really what we needed them to say and see it as is, that's a device that comes to the bedside for every single resuscitation, because it's going to help us do high quality CPR, minimize pause times, and hey, it also happens to defibrillate should we need it. And so we really started this campaign around that to start getting staff buy-in. Like I said at the beginning, staff need to see why you want them to do this and understand the then downstream effects of the outcomes that you can improve. So this was kind of our first initial steps. And I will say, we don't have a ton of time on this webinar. I could spend a whole webinar just talking about each little step that we did and really diving into that. So I'm really giving you a very high level view of the approaches that we took, and my email's at the end, and I'm happy to answer any additional questions, via email or at the end of the webinar. So just know I'm not diving in to all the nitty gritty like our CPR challenge and things like that. One of the things we really started doing was closing the loop with our staff and really creating some significant data transparency. And so what we do is we create the CPR report cards after all of our events, and we actually, give them their CPR quality. And then at the bottom, we actually give them very specific indicators as to, the green section shows that you are doing great rate, great depth, great release. This section here, we're leaning a little bit more, our rate is a little bit higher. And so one of the most common questions I get about this is, how do you go about doing this when you have that ER team, like Peter said, who is just devastated at the loss of a child that's come in, they feel like they've done a really good job, and now I pull the CPR quality and it's 0%, right? And so this really comes down to the human factors, right? And really meeting them where they're at. Never would I walk into one of those events and say, wow, you guys did a terrible job, right? Because the reality is in so many, especially in these traumatic cardiac arrests that come into the ED or in the, back of the ambulance, there's a lot that you can't control. And so what we really want to focus on then are, what are the things we can control? Maybe we can't control the 30-second pause while we're putting in bilateral chest tubes and trying to get, an airway in. But what we can control is to make those as short as humanly possible with high quality communication. And when we get on the chest, making sure that we're doing the highest quality of compressions. And so we give people very, very real, tangible steps that they can take the very next time. So on this, for instance, kind of the last bullet point is, you had 2 pauses greater than 10 seconds. Here's some tricks to try next time to really help minimize those pauses. So we're not just saying to them, wow, you didn't do very well. We said, here's where we identified some opportunities. Here's exactly what you can do as a team next time to help fix that. And it really started to get some significant buy-in. So over the course of 2017 through 2021, we saw a 10-fold increase in our CPR quality. So we went from 4% to 4.3%. But we had to ask ourselves, what continues to lead to poor quality CPR? Because 43% is still not going to be sufficient for my ECMO surgeon for the amount of time that the ECMO pump is working. And so we started to take this very deep dive with our clinical staff to really say, what is it that is leading to this? Because nobody wants to go to the bedside and do poor quality resuscitation. That's not in our, DNA as healthcare providers. And so what we did is we, my thing did not show up. So we actually process mapped our entire from code call all the way through the debrief. And we really started pulling out what are the key things that are making it challenging for you as a team to achieve high quality CPR. And we found that our CPR feedback device didn't always have a consistent place. We didn't have consistent roles. We didn't have high quality communication. Kind of like Peter said with that picture, right? It's kind of who's doing what. There's a lot of people, and we're not really sure what everyone is doing. And so we took all of the staff feedback, we looked at data, and I steal shamelessly, 95% of what I'm presenting today is because somebody else came before me and did it and showed that it worked. And I said, why reinvent the wheel, right? And I would encourage all of you to do the same. Like, if you like any of this, don't reinvent the wheel. Just reach out to me and I'll happily share things with you. And so what we did is we really took from Betsy Hunt's Code ACEs paper, this idea of choreography. And so we do use Zols. I'm not, this is not about Zol. You can do this with any particular device that gives you feedback. But we developed this cart that gives them all the things that they felt they needed right there at the bedside. We didn't have step stools readily available. We couldn't switch pads super easily. And so we really wanted everything right there. And it goes right under the monitor. So they have in line of sight for physiologic indicators. In the ED, I recognize you will not have arterial lines, but you may have end tidal. And if it's hooked up to the bedside monitor versus the defibrillator device, that gives you that ability as the team leader or a part of the team to kind of have that direct line of sight of all of those key metrics. And then we built the choreography around the CPR feedback. Because what we found is oftentimes a CPR feedback device doesn't even get invited to the kids' table at holidays, let alone the adult table. And we really felt like this needed to be at the center of that adult table, really being the centralized part that allows us to do this high quality CPR and hopefully improve outcomes. The other thing that we found was that we were not following feedback. And so we really took a step back. We looked at adult data, we looked at pediatric data, which there isn't a ton of pediatric data on release velocity. But we really took this step back and said, gosh, does everybody actually understand the physiology of each part of the compression that they're providing? Because so often we say push hard and push fast. And I think we sometimes forget about the physiology that happens with the release and the depth, with the release needing to be rapid, complete, to create that negative pressure, fill the heart, mimic diastole, and perfuse the coronaries. So if we're not releasing, we're not filling the heart. And I always say to staff, if you want this heart to restart, you probably want to get oxygen to its coronaries, right? And so we really started focusing on this release component. And we said, if you quickly release and allow that full recoil, you're perfusing the heart. Then you're primed and ready to then achieve correct depth to perfuse the brain. And that rate of 100 to 120 really allows you to achieve those two things. So we shifted our focus off of, you must only compress 100 to 120, although that is obviously a part that we talked through, but we really focused on the release and found that things kind of fell into place. So we started teaching CPR like this, that your downward stroke is perfusing your brain, your upward stroke is perfusing your heart. So each piece of your compression is equally important. And it was amazing the light bulbs that started going on with our staff. Because I had my own aha moment as I started realizing this, right? Because we're not taught the physiological things that are happening in each segment of CPR, I think, to the level that give us the why. Why is it important that I fully and rapidly release? Why is it important that I achieve correct depth? Well, this is why. Because we're perfusing the heart and the brain. And if you don't allow that full release, you now don't have a full heart to now perfuse the brain. So now you're not perfusing anything. And we really started on our way with this modified CPR technique. And this is where, of course, I give my caveat again. This is not endorsed by the AHA. We also saw that we were having significant pause times. This is a 27-second pulse rhythm check pause time, 9-second pre-shock pause, which in our book was far too long. And so we really we really used all of this data, as you can see, that we were getting from our CPR quality. And there's so much other data that we collect. I'm just focusing on CPR quality right now. To really say, where are the gaps that we're consistently seeing trends, and what first step, second step, third step can we take to really start improving that? And so with our pauses, we really started talking about processes that they could do to really minimize that pause time. My favorite is finding the pulse while you're doing CPR before you pause compressions. Really the communication among the team. If you're the person charging the defibrillator, making sure you're saying, keep doing compressions, keep doing compressions. Otherwise, that compressor is not sure that you see them and that you're going to clear them. But if you're saying, keep doing compressions, they know that you are very cognizant that they are there and you will clear them. So they keep doing high quality compressions. And then all of us have seen the Hollywood clear, right? Clear, and we step 10 feet away from the patient. I'm clear. And so we really started teaching the hover technique of, there's nothing different besides you're not taking 10 steps back. You're still clear from the patient. And then that action linked phrase that really Betsy Hunt really coined with her CPR coach work and her codeasis work is really, okay, shock is delivered, resume compressions. So really identifying not only the roles, so we know who was who, the choreography of where is everyone standing, and then how do we communicate to each other to ensure that this is high quality resuscitation. So following some of our work with our pause times, this is some events that happened shortly after. So this is a 5-second pulse rhythm check and a 3-second peri-shock pause time. I will say the first time the 3-second pause time happened, we were like, that might be a fluke. The second time it happened was in a different unit, and we said, all right, now we know it's possible. So I'm going to, challenge all of you to go to your agencies, whether it be adult or pediatric cardiac arrest, and this is your goal, a 3-second peri-shock pause time. It's about a 1.5 pre, 1.5 second post-shock pause. And so as we come to an end, really, I have just flown through 7 years of work. So, this is not an overnight thing by any means, but really to kind of give you a glimpse into what difference it's made. And really my hope today is to give you a glimpse into what is possible by using data to drive change. So first and foremost, when we talk about the prevention piece, it's been 371 days since we have done CPR in our acute care areas. So that's outside of our ICU, ED, and surgical service area. So any of our floor medical surgical units, we've not done chest compressions. I purposely put it on wood because I knock on wood every time I say it. But we, our team is doing a remarkable job with the prevention piece, identifying, and that could be a whole nother talk, prevention of cardiac arrest and kind of what the literature shows in best practice. This is our overall CPR quality in our PICU. So this is where we initially started our efforts. It helped I had come from that unit. This is the unit that has the most of our cardiac arrest within our institution. And so it just made sense to start here. And so, now we're looking at median. Before I was looking at averages, kind of just average. But statistically, it's more accurate, I'm told, to look at the median. So here we are. So they started fiscal year 17 with 2% CPR quality. And basically over the course of these 7 years, we have done a lot of this QI. So all the stuff that I flew through is kind of year by year things that we have focused on. Fiscal year 21 is actually when we rolled out the Zolcart and started our modified CPR technique and really started pushing for patient-driven CPR using physiologic indicators to drive quality. And so that huge jump does take into account when they're using physiologic indicators and achieving the goals that we have set. And you can see as of the end of our last fiscal year, they were at 77%, and they are holding steady for this fiscal year as well. Our ED data, I don't have in here. Because we started in the PICU first, our ED just rolled out the Zolcarts and started a very targeted education campaign around the modified technique about a year and a half ago. And you see this same exact like huge spike in their CPR quality. They're able to use end tidal because we're getting that device to the bedside much easier. And so they started at about 2% as well. And they're up into like the high 50% range. And I have no doubt that they will continue to improve that quality. So overall, they're doing a remarkable job. And it's really been because we've used data to really drive change and give them that why. So I'm just going to go through a quick case study that we had at our institution not too long ago. This was a previously healthy child that came in and had a cardiac arrest in our pediatric ICU. It was a shock that led to a cardiac arrest. This is our CPR quality metrics that we can pull pretty easily from our device when we pull the data. So to kind of orient you, if you have not seen this, the top line is the yellow bar is basically just showing the CPR segments. So when the child's getting CPR, the second line is the depth. Anything that's blue is within depth, the normal depth. And you will notice that we allow depth from 2 to 8 inches. And again, not endorsed by the AHA, but we do that because the sensor that we use is only an anterior sensor, and we don't have the luxury of somebody being on the ground. And so they're on a bed with a mattress, and even with a backboard, we do notice that there's a little bit of that mattress lag. And so we really want to make sure that we're not telling people to do compressions that are too shallow by saying, okay, you can't go over 2.4 inches. So that's why they're measuring so deep. And, we are tracking if we're having increased injuries or anything like that. But that's not what the patient's actually getting. Rate is the next line. So anything blue is within that normal range. And then the very bottom is our release velocity. So it's looking at the speed of release. And there is some adult literature that says if you're above 400, it is independently associated with intact outcomes. And basically anything that's blue is a release velocity over 400. So you can see the two things that really matter, perfusing the brain, perfusing the heart with release and depth, are nearly 100% quality. We also have shocks. The patient was defibrillated 10 times through the event. And you can see that that first set of shocks were 5 to 6 seconds. Second set were 7 to 8 seconds. And then that third set was, 5 to 10. So the longest peri-shock pause that we had was 10 seconds, with our shortest pre-shock pause time of 1.2 seconds and our shortest post-shock pause time of 3 seconds. So I share this with you because it's possible, right? And this is the case that still to this day gives me goosebumps. The patient actually walked out, it went on to ECPR. I think that's an important piece to mention, and ended up walking out of our hospital neurologically intact with a normal MRI. And so what you see here feels impossible to achieve. And I can tell you, when I started this work, I never, ever in my wildest dreams thought that I'd be able to be at Dr. Antevy's webinar, like sharing this, because it feels impossible, right? But with data and really driving change using that data, you can achieve this. So this is our organization-wide outcomes. So overall, median CPR quality is the line. The bars are our risk-adjusted survival. So we've increased our risk-adjusted survival from 33% to 45%. We are holding steady and kind of ticking little by little in the 45 range. But when we calculate it, that's about 10 to 12 additional children a year that are walking out of our hospital. And to those families, you know, I can speak from experience, right, that they are grateful for the work that we've done. And so I'm sure, like, kind of as we come to an end here, many of you may feel like you're already on the top of Mount Everest. And if you are, if you could just drop your email in the chat for me so we can have a conversation, because I have lots to learn from you, that'd be awesome. But many of you may feel like, yeah, this is really nice, Jen, and you have a dedicated resource. I'm only part-time, so I think that's an important piece. I think a lot of people think, oh, you just have all the time in the world to do this. And I started this as a PICU educator, so I did not have dedicated time at that point. So if you feel like you're at the very bottom, you're probably thinking like, where do I start? And I always like to tell people kind of that first step, right? The most important piece of advice that I can give you is start with one thing. Pick one thing. Because we've just talked about 6 different things we've done to improve CPR quality, and that feels overwhelming. So it doesn't even necessarily need to be about CPR quality. What data do you easily have access to? How are you guys doing with pre-arrival setup? You know a pediatric cardiac arrest is coming in. Do you already have the weight? Do you have the doses pulled up? Do you have everyone ready to go? Oh, what's your number of cardiac arrest events? What's the etiology, out of hospital versus in hospital? How are you doing with epi-dosing, epi-intervals? I mean, that is right off of your code documentation. You don't need a fancy device that's going to give you the data. What are your pause times? That can be as easy as standing there and kind of having somebody that's your secret shopper, you know? And then if you do have the ability to pull CPR quality data, what does that look like? So you're going to collect the data on whatever one thing you choose. And if you can easily collect data on the back end and just kind of throw it into a folder for later use on the other stuff, that's great. But I want you to focus on one thing. And then you're going to collect that data. You're going to then start identifying gaps and trends that you see. And you're then going to say, what's one change that we can make to move the needle on this one piece of our pediatric resuscitation? And then when you fix that, or you start to see that that's getting into your culture and embedded into your culture, you then go to the next one thing. And I always joke that once you peel back the layer, the onion, there's tons of layers, and you will forever have job security because you start seeing all of the opportunities that come to you. So I'm going to end with a couple things to just try to help you feel encouraged. First of all, this is a book that I received from a dear friend, and I literally opened it, and this was the page that it came to. And I think this is so incredibly important for every single one of you, because if you're taking your first step or you're, way along this journey, we always all feel like we have such a long way to go, sighed the boy. And the horse says, yes, but look how far we've come. So even if you've only taken 1 or 2 steps, you've still taken 1 or 2 steps that other institutions may or may not have taken. And that's 1 or 2 steps that are going to get you closer to improving children's resuscitation. So with that, you probably are all wondering how Micah's doing. So he continued to grow and thrive, and he is now 7 years old. He loves the Oilers. He plays ice hockey and is doing remarkably. He's in 1st grade, and really, truly, no one would ever expect that he made such a dramatic entrance into the world. I leave my neurointactness up to all of you, but I can tell you that he is a completely normal 7-year-old. And, I can't emphasize this enough that our resuscitation and CPR quality matters. It matters to the loved ones. It matters to the patient. And behind every single number that we look at is a person. And it's a person who is somebody's most loved one. And I am so incredibly grateful that our team, our EMS team, our dispatcher, everyone that came into contact believed that. And so I'm going to leave you with my quote that keeps me going. And there's my email there, so don't hesitate to reach out. Unless someone like you cares a whole awful lot, nothing is going to get better. It's not. So it takes one of you, one person, to start the ripple. And I want to thank you so much for giving me the time.
Wow, my heart is just full of joy right now, Jen. That was an incredible presentation. Thank you so much. It's funny as you were speaking, and actually, Dan, before you share, I have to make this up. I was thinking that we got to put you on a bus, and this I just created this on OpenAI, ChatGPT, and like we need to get on the Resus bus and go around this country and teach everybody what you're doing.
Let's do it.
Let's do it. Let's do it. We need a bus sponsor. Anybody want to sponsor the bus?
Yeah.
I want to leave time at the end, and I want to get Dan in here. But what you spoke about was just start with one thing, collect the data, and then start to peel the layers of the onion. I hope everybody takes that to heart. Now I hope everyone sees why I think the world of you, and you have saved so many lives. Thank goodness that the man upstairs decided that you needed to be saved, as well as Micah. You're doing amazing work. So thank you so much. I do want to leave some time for at the end for questions, and if we go a few minutes over, I'm sorry, but I now want to bring in someone who I've worked with for over a decade. I'm so grateful now that he works here with us at Handtevy. And Jen spoke about she was gracious enough to talk about EMS and the hospital. And I do see those two things as one, because cardiac arrest is cardiac arrest. So I want to hand it over to Dan to talk about metrics in the out-of-hospital setting, and then what you can do as an EMS system to go and find the Jen Hayes of the world and say, hey, let's collaborate. So without any further ado, Dan, take it away, my friend.
Thank you, Doc. So I'll keep this real quick. We're going to try and still stay on time. But basically, this was a training room, Davie Fire Rescue. We trained extensively in high performance CPR, having a pit crew schematic. And a lot of you are on right now from the emergency room and from the hospitals going, well, this doesn't really apply to us. And I understand that viewpoint. The challenge that we have in EMS is we train so hard because we have the availability to do that. And we practice regularly. Our crews come together and train. But then we get to the emergency room, and a lot of times it doesn't go smoothly. The handoff is rough. The transfer of care doesn't go well. The care that the patient actually gets decreases. And that's really the call to action that we have today. We want you to be a part of this journey. We want you to partner with your EMS and realize how we can work together. So this is a very quick, I'm just going to show the video for a minute. You're going to see the captain is running the code right now. He's got CPR assist running on his tough book, which I'll show you in a minute. Everybody on scene has very minimal, quiet communication. And this is just to show you that we're all organized. We have a plan. It is that pit crew philosophy. The device that was running all this is CPR Assist. Full disclosure, this is by Antevy. It's on Handtevy Mobile. This will provide care with guidance on your compression rate, on your pre-charge notifications, on your 2-minute intervals, on your epi administration, making sure you're within your 3 to 5 minute window. It provides guidance on all the care that's happening for this patient, and it's documenting all of it in real time as well. So we're big believers of this being a tool that provides a solution for organizing that code. So what does it look like? Well, we actually have the data that shows what it improves upon. Our compression rates are now performed perfectly at 110 per minute. Our rhythm checks are regularly occurring at 2-minute intervals. Our pre-charge is happening every minute 45. Our ventilations are being performed 10 times per minute. That little image you have there is a code stat. This is that monitor file, very similar to the case review that Jen showed from Zoll. This is from Stryker on the LifePak. And we're able to track all this all the way down to that green bar, which indicates we achieved ROSC in our patient. We got pulses back. We know this works. We have the data to prove it, and we'd happily share all the information with it. So when we go into the EMS world, this is everything that we're getting from our LifePak for our code stat, and any hospitals that have a LifePak 20 or any LifePak and Stryker product would be able to access the same data file. So as we go through it, when we say we go into the emergency rooms and we train and we practice with those providers to improve the handoff, we mean it. This was a video from one of Dr. Antevy's agencies in Palm Beach County. That's Chief Charlie Coyle, amazing chief, dedicated, passionate provider who practiced this. They showed the ER staff what it looks like in the pre-hospital environment. He showed them what the crew's actually going to be doing, how they perform care, how they're organized. So again, just showing that organized, very professional response that's being guided with CPR assist, and all the care is being documented real time. So what is our call to action? In the swap shop, We are tired from an EMS point of view of bringing in a patient that's gotten the highest level of care possible coming into the ER, and hey, that eye gel that's providing perfect ventilations needs to be ripped out. We have to intubate this patient and we have to pause compressions for it. Hey, that life pack that was showing all the modern rhythms on your patient, rip it off. We need them on our monitor. We can work together and do this code the same way we were doing it in the pre-hospital environment, the same way that the ER care needs to be provided, and work together. Because from code stats that look like, the one on the left there, where there are opportunities, to the right side, you see the compression rates go as high as 170 beats per minute. We know compressions that fast are horrible for patient outcomes. And we're seeing the ventilations go up to 30 plus times per minute. We know this is very painful. This is horrible for patient outcomes, and it has to stop. And that was the hospital that's providing that level of care. When we look at pediatric cases or adult cases, we look at every part of that code and send that feedback to the personnel. That is so critically important. And if you're in a hospital, if you're in the emergency room, and after your cardiac arrest, you're knocking that data that Jen showed or that I'm showing now, that is another call to action. You need the data in order to measure and improve care. When we look at all the pauses, we look at all the interruptions from intubation attempts, from checking the rhythm, looking at the actual transfer of care. Again, it's painful for us. We don't want to see this poor data. So what does the future look like? And I have 2 slides left, everybody. We want to train with you. We want EMS to be a part of the hospital response. We want to be in the code room. We don't want to have the curtain closed on us. We want to be standing right next to the physician or the code team leader and actually going through everything together. We can use our tools. We can use CPR Assist to guide the rest of the code, making sure we're on track for our epi timers, for our pre-charging, for our defibrillations if they're in a shockable rhythm. So we want to avoid that curtain close. Don't kick us out of the room. Don't swap out all the equipment if it's working correctly. And if you're unfamiliar, ask. Say, hey, I'm not familiar with that supraglottic. What is it? And how do we know it's working well? EMS personnel can stay in that triangle of care. We can continue providing excellent care with the ER staff. All right. It's a warmer handoff. If you've enjoyed today's webinar, which we so hope you did, please know that we're having another one, April 16th. This is CPR Mastery in the Adult ED. We have Dr. Mock and Dr. Myers on, along with Dr. Antevy, and we really want you to be a part of it. So if you enjoyed today, and if you're looking forward to the CE, which is our next slide, we want to make sure that you join us next month. Doc, did you want to make any comments about next month's webinar?
No, just I happened to meet Garrick in the same room that I met Jen. So I'm very appreciative of that. Again, high performing people who found Jen, you'd be, I mean, I know you saw the presentation, but Garrick did the same thing that you're doing on the pediatric side and the adult side. And guess what he found? 2% of the time were they in the range for compressions, 2% of the time. So again, it's very striking to me that, and I think that your comment was very beautiful earlier, where you said that if you don't measure it, you have no idea that it's happening, and you can't just pat yourself in the back and say, "I'm damn good," because you're probably not, right? And someone's asking for a link to the next webinar. I'll put that in the chat as well.
And then the slide that you all have been anxiously waiting for, and we'll also put that link in the chat. This is to claim your CE. So we're very thankful again for our partners that have allowed us to register for this through CE Broker and through direct CAPC reporting. So whether you're EMS or RN, doesn't matter. We want to make sure that you get the credit for attending today, and we hope you'll be a part of next month's. We'll be issuing a CE credit for that one as well. Doc, do you have that link handy, or do you need me to post it?
Yeah, I just posted it.
Okay, great.
And thank you so much, Dan. And we actually had very good timing. And Jen, Dan, and I both want to thank you so much and my entire team. Also, would you be okay staying around for a couple of questions if we wanted to open it up?
Absolutely.
All right. As everybody knows, I am adamant about having Zoom webinars that are open, that are one big family. We don't do webinars behind the wall, and we do that because we want you to come on and give us your thoughts and be part of the conversation. We don't want to be in a vacuum. So does anybody have any questions or any comments for Jen? And want to unmute your microphone and ask it publicly. I'll start if nobody has a question. And if you do have a question, there's Rob Sanders, our friend Rob Sanders from Massachusetts. Rob, go ahead.
All right. Hey, can you hear me okay?
Yes.
Perfect.
Right. So something you mentioned, mentioned this to Dr. Antevy over through the years, is that the first step um, before you introduce techniques and changes and concepts and so forth is you got to get a permanent change in behavior. You have to have people committed to doing it. And you mentioned that several times. And I couldn't agree with 1,000% more. Whether it's fire rescue, EMS, whatever, is, someone once said when education is truly occurred, you have a permanent change in behavior. So if you can reach in and grab somebody's brain, their character, and make them committed that we're going to do this, the rest will follow. So hats off to you. That was very powerful, and thanks so much for today.
Yeah, thank you. Yeah, and I couldn't agree more. And it's really about like inspiring our staff. And I think that's the foundation of making that consistent change. Because they start to see that those little changes actually do equal improvements, and then they're bought in.
So Jen, that's a great question, Robin. Great answer. Wesley Littleton asks, can you describe again the importance of compression recoil that creates negative pressure, as well as the credit card release? Go ahead.
Yes. So how we teach it is, I used to call it the credit card technique. I stole it from Dan Davis. And we were kind of doing this before Dan and I met, but I then was told we don't swipe credit cards anymore. We tap them. And so now it's the modified CPR technique because then it's timeless and it doesn't matter how we pay. But basically what we do is we really teach that rapid release is necessary to create the negative pressure and fill the heart. And that is basically mimicking diastole. And so during that rapid release and the fill of the heart, your coronaries are also being perfused and getting everything ready to go then for that proper depth to then perfuse the body. But what we really care about, of course, is the brain. And so that credit card swipe compression, modified compression technique that you saw pictures of is we actually have people lift the palm of their hand off of the patient's chest. And so it really forces them to fully remove their weight and allow that patient's natural release velocity to happen as quickly as their physiological, chest wall can release to create that negative pressure.
And that's a great explanation. It's very important to understand there's only one set of arteries in the body that get perfused during diastole, during the relaxation phase of the heart, and those are the coronary arteries. Every other artery in the body gets blood when the heart squeezes. So it's so important. And actually this morning we had in our office at Handtevy, we had our CPR AED day. And so everybody here was doing CPR. And Jen, we mentioned the credit card because everybody was leaning because you get tired and you start leaning. And you said, every time you lean, there's no way that heart is coming back to life. But it's these small things that are so important there are metrics out there that can actually show you the release and the release velocity. Those data are there for us. And just to circle it back around, I see we have another question coming in. Just to circle it back around to the pediatric readiness, they're not looking at any of this, right? So this world of pediatrics, to get things right, there's like one big bucket here, but then there's this whole other bucket when it comes to resuscitation of really getting it right and really taking it to another level. And I hope that's what you learned today. Sherry Worley, I hope I said that right, Sherry, says, I often use a Doppler so the room can hear the real-time heart rate during compressions, then immediate auditory feedback during pulse check. Have any studies been done, Jen, that you know of regarding this and whether it improve outcomes?
I do not know of any, but Peter, I'm going to open it back up to you. Do you know of any?
Well, I must say it to Sherry. We're big fans of ultrasound. We have integrated it into our EMS systems. Where we use it is in cardiac arrest, because what I will tell you is that, especially in pediatrics, this concept of PEA, pulseless electrical activity. But the P, the pulseless, is all based on whether the human finger can feel a pulse. And oftentimes in children, you could have, electrical activity on the monitor, but your finger cannot feel the pulse. So we've had a number of cases in my department where it looks like there's no pulse. It doesn't feel like there's a pulse. We put the Doppler on. We do see a pulse. And indeed, these kids are just hypotensive. You can't feel the pulse. So they don't need cardiac arrest epi. They need what we call push pressure epi.
Yeah.
So while we haven't used the Doppler, which I think is a brilliant idea, as long as it's not getting in the way, it's a brilliant idea because now you have an audible form of actually determining whether or not you have a patient who's alive or not. I don't know of any studies that have been done on it, but I surely will do that research here after the call.
And I want to
nice.
add in, just as we're talking about pediatrics, one thing I did not share just because of time is we actually have the breakdown of CPR quality based off of age. And, there's white papers that show this of multi-center trials. Infants by far get the worst CPR quality because they're so easy to just kind of sink into their chest, squish them into your hands, right? And then our adrenaline's going because it's a baby. And so we've actually taken that modified technique and actually started to use it on infants as well, whether we do single hand with that modified technique or we don't squish the infant into that encircling hold. We kind of put our hands to the side and still do our 2-thumb pull up, but it's that modified technique that we're fully lifting off the chest because we do find that infants get horrible CPR nationally.
And just for an additional data point for everybody to know, infants are 4 times more likely to go into cardiac arrest. So if in your career you're going to see cardiac arrest, it's going to be in an infant 4 times greater. Infant meaning under the age of 1. So you really ought to know how to do that. And again, oftentimes in EMS, it's because it's that 7 a.m. call where mom or dad has rolled over and slept on the child by accident, the co-sleeping problem. So infants, you're right, don't get great CPR. They're portable. So people just pick them up like a football and then run, which is the wrong thing to do. We do believe you should do it right, do it on scene. Don't get scared, don't run off, because when you come into my emergency department in full arrest, the chances of you coming out of my emergency department alive are very, very slim, maybe 0. Out of hospital cardiac arrest is an EMS thing. As Jen mentioned, the high performing hospitals in hospital arrest is up to 40+%. And you've seen what CHOC is doing now because of that. So out of hospital cardiac arrest, unfortunately, today, the neurointact survival is only 5%. 5%. And that's because of poor bystander CPR, poor dispatch CPR, telephone CPR. The police officers often are afraid of doing CPR. EMS then runs off the scene with these kids and they're not doing good CPR on the scene. So you end up having these links that are completely not even touched. They're not even in the same room, those links. They're completely broken. We have a few more questions here. So Jen, Lindsay says, you are sponsored by Zoll. However, are there feedback devices that you have noticed that work better than others? Any comments on that?
Yeah, so I have primarily used Zoll feedback devices, though I know that there are plenty of others. I will say that the type of feedback device that you use is actually not the most important thing. I always say you cannot put a Stryker or Zoll at somebody's bedside and just expect it to improve CPR quality. The most important piece of using feedback devices is making sure that the staff know how to interpret the feedback they're receiving and make real-time changes. And so if you can do that, regardless of what feedback device that you use, you will be able to achieve higher quality CPR.
Right. Great answer. And I think Dan also put in the chat, there's basically 2 main companies that do this. You need to do your due diligence and go figure out which one is best for you. There certainly are differences, but this is why this webinar exists, because a lot of people, and I would venture to say, I've traveled to all 50 states many times. I've been in many hospitals. I will tell you, there's not a hospital I have been in that is actually doing what Jen is doing. Let me repeat. There's not a hospital that I've been in that's doing this. because I haven't been to Jen's hospital yet. Her hospital is doing it, and maybe there's a sprinkling of others. But if you're on this call and you're doing it, God bless you and great for you. There's many EMS systems doing this. I can tell you right now, all of my EMS systems are doing this. Let's get this into the hospital. Let's duplicate Jen, get her on the resus bus, and get her everywhere. Reed says, from an EMS perspective, do you have any leadership tips for running a scene in a pediatric arrest? Many responders want to just scoop and go, as we all know that's detrimental. Yes, you're correct on that. What can we do to convey to those on scene that staying on scene is the best course of action? I could spend 18 hours on that one, Reed. You can go to our YouTube channel and you can see we're very opinionated on that. But at the end of the day, just like Jen's doing today and educating us, here's what I would recommend that you do. Very simple. You go to that agency who's scooping and running, and you're saying, show me all the cardiac arrests you've had over the last 24 months. Pick 2 years because it may be a small number. Find out how many of those kids are walking, talking like Micah, playing soccer today, right? I'll bet you in an agency that's scooping and running, the answer is 0 or near 0, right? That's how you start. Just like Jen said, go find out what your baseline data is today, right? Put on, like Garrick, who's coming on next month with Victoria. They just put on the monitor and they didn't tell anyone what they were doing. And they said, how well do you think you're doing? And they said, 90%. He said 2%. And they all didn't believe him, right? So I would say, Reed, go get that data. It's readily available because all you do is query it. And then you call the hospital and say, I have 7 charts. I want you to tell me what happened to those kids. And they'll say, oh, this patient was discharged. Great. Or this patient was not discharged. They were in a morgue, right? Look, that's where you start today. That's the one thing that Jen said to do in EMS. That's the one thing you ought to do. And I went to a town, I'm not going to say the state, where the pediatric hospital was telling the EMS system, don't listen to that Antevy guy because we just want you to bring those patients to us. The chief, God bless this guy, he went and he said, we had 50 arrests in the last 2 years. I want all their outcomes. All 50 of those kids were dead. None of them lived. He called me up and he said, we're doing this. And he was the one champion. He was the Jen Hayes of that city. And he said, I'm going to make it happen. So there's going to be the naysayers. There's going to be the greater than thou doctors in the ivory tower who are going to say to you, Reed, you're wrong. We know better than you. Go to the data. Go find the kids. Period. End of story.
And I would add to that I know we're short on time, but the education piece, I didn't get into any of our education or simulation piece of this that just consistently reinforces. And so we do a lot of what we call first 5 throughout the entire hospital. So what are those first 5 minutes of resuscitation look like? What is the order of priorities? What is the communication? We're all very comfortable with each and every step in the order that we're going to do it in. And so I would say get the data, because our data showed we don't do this first 5 well. And then that's where we really focused our efforts. And so then being able to do education, and it does not have to be high fidelity. I think so many people get caught up in this, oh, I don't have the highest fidelity mannequin. I've done first 5 education on a bear, like a stuffed bear. And so like it's really getting them to go through the motions and have it become muscle memory. And so once you have that data, then being able to have them practice with that pit crew style, staying on scene, what does our pediatric resuscitation look like? And what are our order of priorities and most important things we're going to focus on to get ROSC before we go to the, transfer.
Amazing. How many, actually, I want to put, before we end, I have a question for everybody. I put the CEU in there again, is how many people want to hear more from Jen Hayes? Because I can tell you that I can listen, everyone, right? So, Jen, as I told you yesterday, I think that we need to create the master class, and you could help a lot of people. You could help a lot of people. So, we will. I'll try and convince her and twist her arm, or we'll get the resus bus. But yeah, see, a lot of people are saying that they want to hear back from you. So, Jen, thank you so much.
Thank you. Thank you for
give
having
a hug
me.
to your amazing family, and
I will.
thank you for all that you do. And we can't wait to see you again and hear from you again. And hopefully I see you at another conference sometime soon.
Yes, hopefully soon.
Okay.
Well, thank you so much, you guys.
Thank you so much. And
Yeah.
Dan, thank you as well. All right, everybody. We'll stay on a little longer just in case you need the CE link, which we're going to put in again and again. Our partners at FlightBridge Ed, thank you so much for making that happen as well. Nursing CEs, we'll take care of that too. And we really appreciate everybody. Go out there, make a difference, and don't let anyone tell you no, right? That's what we do here. So have a good day, everybody, and good to see all of our good friends. Thank you, guys.
Goodbye.
Okay, bye, everyone.